So for our participants, we've gone through diabetes and management, both diagnosis and management during pregnancy. And today we're just going to touch base on intrapartum and postpartum follow-up for our diabetic patients. Next slide. So we're going to do a little bit about gestational type 2 and type 1. Gestational diabetics, when they come in for delivery, I typically will have them take their evening medication if they're on medication. I have them hold their morning medication, and then I manage them as an inpatient with a sliding scale of insulin, typically just sub-Q doses. There are occasions that a gestational diabetic might need to have an insulin drip, but it's less common. And during labor, I typically will check their blood sugars every 2 to 3 hours. Postpartum, while they're in the hospital, people manage this differently. So just a little bit about what I do is check either their fasting blood sugars while they're in the hospital, or one good way to do it is just to check one full day of blood sugars of fasting and then 1 or 2 hour post meals. And then if those are normal, typically you don't have to check anymore. Next slide. So what I like to do after that, we know that if their fastings are less than 100, they're non-diabetic. If their fastings are really elevated over 126, that is abnormal. And that is enough of a criteria to make the patient labeled as a diabetic. Typically it's a type 2 diabetic, but that can be figured out later. If the patient needs a 2-hour glucose tolerance test, we use the values of less than 140 being normal, greater than 200 diabetic, and in between pre-diabetic. Now, everybody is doing this a little bit differently. I just read a paper this past week from the Green Journal where they're actually, the study showed very good reproducibility of doing a 2-hour glucose tolerance test in gestational diabetics while they were in the hospital after their delivery. So they advocated doing it before the patient went home. And the reason for that is just, we all know these patients are very difficult to get back in to be compliant, to have follow-up testing. So that's a novel idea, and we may hear more and more about that being done. Other things that people do rather than doing the 2-hour test is just doing a fasting blood sugar on patients when they come to the clinic. The problem with that is getting them in at the correct time of day to do a fasting blood sugar, and it should be less than 100. Just like I show on this slide, if it's over 126, they're diabetic, and if they're in between, they definitely need the 2-hour glucose test. The problem with fasting blood sugar, again, timing of getting them into the clinic, but the other thing is the sensitivity. It's not as sensitive as the 2-hour 75-gram glucose tolerance test. So if I had my druthers, I'd do the 2-hour test followed by the fasting. Now, some people will ask about doing an A1C, and an A1C is a fine screening test for just well women checks, but it is not very sensitive at diagnosing diabetes. If it's over 6, the patient has some glucose intolerance, and then they typically will need to have the 2-hour test done, but it's just not a very sensitive test. So better than nothing, I would go with the fasting or the 2-hour test before I would do that. Also remember, the best time to do the testing is 4 weeks to 12 weeks after delivery. And the ADA recommends that if a patient has been diagnosed with gestational diabetes, that they should have testing for diabetes every 1 to 3 years during the life because of the 50% risk of type 2 diabetes later in life. So with our type 2 diabetics, I usually will have them take the usual dose of the intermediate or short-acting insulin with dinner at night. And then in their long acting, I would cut in half. So if they're on NPH at bedtime, I turn that in half. And intrapartum, we check their blood sugars every 1 to 2 hours and manage them with an insulin drip if their blood sugars are over our target range. Next slide. So postpartum in our type 2 diabetics, I typically stop their insulin if they were on oral medications before pregnancy, and I restart their oral medication when they're taking a diet. If they're on insulin or had been on insulin before pregnancy, I cut their dose by to a third, cut it 2/3 off, and see how they do with that, because they just don't require as much. And just always remember, we try to get these moms to breastfeed. Breastfeeding decreases their insulin requirements, so sometimes they even require less than the 1/3 of the dose. Next slide. So the oral medications that we use, we've had metformin for a long time, and particularly if they've been on it before, it works very well postpartum. Glyburide also works well. We just don't have as much data on its use, and it's particularly with breastfeeding. The other newer medications are likely fine with breastfeeding, with Invokana being the one that we just have no data on. But we really prefer, if you're going to have a mom breastfeeding, to either use insulin or metformin or glyburide during that breastfeeding stage. And then you can go to the more new medicines that we use for oral treatment. Next slide. Type 1 diabetes, a little bit different. These patients are typically a lot more sensitive. I usually have them take their usual dose of intermediate or short acting with dinner, cut their long acting in half at bedtime, and then in labor, we check their blood sugars every hour and use an insulin drip to try to keep their blood sugars maintained at less than 100. Next slide. And remember, we've all seen this, they have that honeymoon phase where a lot of times in the first day or so, they won't need any insulin, but we cut their insulin dose to 1/3 the pregnancy dose, or 1/2 of the pre-pregnancy dose if we know what they had been on, and usually start their long acting and cover meals with short acting with the Novolog, Humalog, Admelog. Next slide. And that's it.
So thank you so much. And before we go into discussion, this is just to let everyone know about other telementoring programs in our state, Project ECHO, opioid use disorders. And just to note, I wanted to note on this, our next module, which will be starting up, is going to be on substance use disorders and pregnancy. And so we will be having some of the specialists who help with the ECHO opioid use disorder coming over here to help with those didactics. There's also a Hep C telementoring program run by Dr. Divya Ahuja.
Any